Hello guys, today we are going to discuss about Gitelman syndrome, Bartter syndrome and Liddle syndrome. These three topics are easy but maybe sometimes little bit confusing during solving the question, so we have to know some differentiating factor which helps us to solve the question very quickly and easily. Both the Gitelman syndrome and Bartter syndrome are autosomal recessive disease and Liddle syndrome is autosomal dominant disease. In Gitelman syndrome, there is defect in sodium chloride co-transporter and TRPM6 transporter channel in distal convoluted tubule. In Bartter syndrome, there is a defect in sodium potassium 2Cl minus co-transporter and chloride channel and ROMK transporter in loop of Henle. In both the cases, the clinical scenario may be failure to thrive. There is polyuria dehydration. This polyuria leads to frequent changes of diaper or nappy. There is hypokalemic metabolic alkalosis. In both the cases, the patient is normotensive. The patient may be normal to low BP but never hypertensive. In Liddle syndrome, as there is gain of function mutation of the epithelial sodium channel, the patient here is hypertensive. Okay, and here is also metabolic alkalosis and hypokalemia, but there is no dehydration. But in Gitelman syndrome, Bartter syndrome, there is some dehydration due to polyuria. But the hypokalemia that is more severe in Bartter syndrome as there is defect in ROMK channel. Okay. In Gitelman syndrome, there is hypomagnesemia, but Bartter syndrome, there is no defect in TRPM6 transporter, so there is no hypomagnesemia. In Gitelman syndrome, this hypomagnesemia leads to low parathermal level, which leads to tetany, hypocalcemia. The clinical symptom is perioral or periangual paresthesia. In Bartter syndrome, there is no hypomagnesemia, but there is calcium wasting. That is hypercalciuria, which leads to nephrocalcinosis or renal rickets. The symptom is delayed dentition, wide open fontanelle, and a short stature. In lab diagnosis, both the cases has decrease in sodium and the potassium level, but increase in 24-hour urinary chloride level. You will remember that in cystic fibrosis we use the sweat chloride level. Here we are using the urinary chloride level, 24-hour urinary chloride level, which is increased in both the cases. In Gitelman syndrome, there is decrease in magnesium level, and in Bartter syndrome, there is 24-hour urinary calcium level increase. In Gitelman syndrome, there is no drug of choice, but in Bartter syndrome, we can use indomethacin. In Liddle syndrome, we can use amiloride, which is epithelial sodium channel inhibitor. So, in a nutshell, in question, if there is the patient is hypertensive and no dehydration, then the diagnosis is Liddle syndrome. If the patient is normotensive, then we have to differentiate between Gitelman syndrome and Bartter syndrome. Then we have to look for the magnesium level. If the magnesium level is low, then it is Gitelman syndrome. If the magnesium level is normal and there is calciuria, hypercalciuria, then the diagnosis is Bartter syndrome. Okay, hope you are finding it easy. Okay, thank you all.